Hi everyone. Well, I decided to discuss this article that's just been released. It's called High Flow Nasal Cannula versus Standard Respiratory Care in Pediatric Procedural Sedation, a randomized controlled pilot trial. Well, this is my area of interest, so I decided to discuss the statistical methods of this article. They did, let me go to the method section. They tested in a prospective randomized controlled non-blinded parallel group single center pilot trial. They tested the high flow nasal cannula versus the standard therapy, that is the low flow oxygen cannula. This study was from 2016 to 2017. They enrolled children from age 6 to 18 years old. The sample size was not calculated because it was a pilot trial. There was nothing before this trial about sedation for procedures using high flow nasal cannula versus low flow nasal cannula. That is the standard care. And they randomized the patients to receive either one of the devices for respiratory support during procedural sedation, and they did a permuted block randomization, and they stratified according to the age, patients from 6 to 12 years and 13 to 18 years. They were adolescents here, and they did blocks of 6 subjects. The allocation ratio was 1:1, and the allocation sequence was generated manually, and the allocation concealment was ensured by using identical opaque sealed envelopes. An envelope was drawn by the pediatric intensive care unit nurse in charge after the patient was transferred to the procedure room. Blinding was not feasible due to the nature of intervention. As the two devices are so different, there was no way to blind. So they did the intervention comparing the two devices, and the outcome was respiratory instability during the procedure. They compared the oxygen saturation using a pulse oximetry during the procedure. That was the primary outcome. And now we're going to discuss the statistical method. That was the main objective of this video. The trial was planned as pilot trial, so they did not require a sample size calculation. This trial is going to be useful for a real trial, not a pilot one. And they selected 50 patients, and they were equally distributed in a randomized way to compare the devices. Qualitative variables were expressed as numbers and percentages. That's okay, no problem with that. Quantitative variables were expressed as mean, standard deviation, or median interquartilian as appropriate. That's okay with that also. Normality of distribution was tested with the Kolmogorov-Smirnov test. It's good to report this. The sample size is not huge, and they did a block randomization. Each block has only 6 subjects, so normality is difficult to achieve here. And they applied a non-parametric Mann-Whitney test or independent test for comparisons continuous outcomes as appropriate. That was a good choice. And categorical outcomes were compared using Fisher's exact test. That's good because the sample size was small, so Fisher is good in this situation. Intention to treat analysis was applied. This is our next week discussion in PPCR, intention to treat. I've already read it and it is well applied in this situation. So it's not it's a appropriate study design for what they wanted to test, to compare 2 different devices in children, and they did the randomization to the concealment, but the study could not be blinded, fully blinded, because the devices are so different. There was no way to blind the whole study. Anyways, it's a pilot study, and the statistical analysis, I think, is correct in this situation. And they, with this pilot study, they may go to the next step, a huge study and they could calculate the sample size using this pilot study. That's all I have to say. Thank you very much.